So welcome everyone to our very first WEL Dermatology teaching session. My name is Dr. Hussain. I'm a GP. I work in Newham and I am the clinical lead for WEL Dermatology Transformation. Before we start, a couple of housekeeping rules. If you could kindly mute yourself, and also this teaching session will be recorded and available for colleagues who wish to view it and see it later on, or those who can't attend it can view it later on. So first of all, I'd also like to thank Dr. Rebeca, who is a consultant dermatologist at Royal London Hospital, who will be presenting along with Dr. Dilshad, who is a GP, on common skin conditions in primary care. And then I will be presenting at the end, time permitting, on the proposed new community dermatology pathway, along with other exciting projects we have for dermatology. So without further ado, I will ask Dr. Rebeca to start presenting on teledermatology advice and guidance. So let me share the screen. Are you able to see the screen, Rebeca?
Yes, I am. Thank you, Nazmul, and thank you everyone for attending this teaching session. I'm delighted to be here. As you probably know, we've been running this teledermatology advice and guidance service at the Royal London Hospital for at least a year, and it's proven to be very popular. It has definitely exceeded the expectations in terms of activity, and as well, lots of things have happened since the last time we talked about teledermatology. With COVID, things have changed completely. So I thought this would be a good opportunity to relaunch the pathway, introduce it to new GPs that perhaps are not familiar with the service, and review some aspects of the pathway that are important in terms of compliance with the standards of the teledermatology. So I think, can I move the slides myself? Nazmul, can you please pass this next slide. Next slide, please. So as you know, we offer this teledermatology pathway to help you manage the most common skin conditions that you see in primary care. So it's open for local GPs to send us a referral letter with some photos, and after appropriate consent signed by the patients. And this is open to manage the most common skin conditions: acne, eczema, psoriasis, inflammatory skin conditions, hair problems, nail problems, low-risk skin cancers such as basal carcinoma, actinic keratosis, or Bowen's disease. Next slide, please. It's the most important message today is the exclusions, which are the conditions that we would not like to see by advice and guidance. So the service is open for adults only. Children's at the moment is not something that we are able to provide, although my colleagues, Dr. Brian McDonald and Professor Adelotul, are currently piloting this for children with 3 practices in Tower Hamlets, and hopefully this will be open for children very soon. But at the moment, this is only for adults. It's not for two-way path referral, so any lesion suspicious of squamous cell carcinoma or melanoma should be referred to clinic under the two-way pathway. I know some of you have used this service for me to give you an idea about the appropriateness of a mole to be referred as a two-way pathway or not. So this is fine, but mole in itself without dermoscopy, I wouldn't be able to comment. And most of the times I will probably advise you to upgrade as a two-way because you put me in a very difficult position with a photo only, without full skin examination and dermoscopy. Dermatological emergencies are also excluded from this pathway because the aim of this is to respond within 5 working days, and severe skin conditions should not be wait for that long. And as you know, and if you didn't know, this is for us to remind you, we are available 24 hours by a switchboard, and we're going to give you today as well the mobile number of the dermatology SPR on call, 9 a.m. to 5 p.m. as well. Initially, I had suggested we should exclude lesions that involve intimate areas or genital areas because I thought patients would find that this wasn't appropriate. But feedback that I received from GPs was actually patients prefer to use the pathway because we respond so quickly. So as long as obviously patient consent and dignity is preserved, there is no reason not to use it. Next slide, please. So as I said, lots of things have happened since we talked last. COVID has changed the way dermatology services manage their patients, and in fact we have all been encouraged to use advice and guidance. So we were very lucky to have this service already in place at the London and working from the beginning, so we were able to accommodate these referrals and to manage your patients safely and efficiently. So now we're all being encouraged to explore advice and guidance, not just for general dermatology, but also for other referrals, including TB weights. And this is something we're considering, and we will be piloting very shortly as well. Next slide, please. This is a graph that shows the activity of our pathway since we started. And as you probably know, the service was formally commissioned by Tower Hamlets in July last year. And in the first few months, we started receiving 5 referrals per day, and we are now receiving 10 to 15 referrals per day. So it has definitely exceeded our expectations, and it has put a little bit of pressure on the capacity to respond within 5 working days, and we are trying to expand that capacity as fast as possible. But it's going, as you can see, it's quite popular, and I think it's probably related to COVID and not just because of the quality of the response that you receive. Next slide, please. So I also wanted to share with you a very important document that was just published last month. It's a teledermatology roadmap for the next couple of years. So as I said before, all dermatology departments are now encouraged to use teledermatology as the main way to manage their patients, to use it for provide advice and guidance, and also for triaging of referrals. Next slide, please. And there are 2 main principles that we need to follow, and this is part of why I think this presentation today is important. First of all, is because patients need to be kept informed about which pathway they are at every moment, and that includes explaining them exactly why we are asking for them to have a photo, why is that important, and gaining the informed consent is key. And the other main principle as well is that the teledermatology should not add burden to primary care or secondary care. So we thought it would be important as well to produce some referral forms that will help you to give me the minimum clinical information that we need to respond the referral, to give you the best chance to have the most accurate advice. Next slide, please. So as you know, our teledermatology pathway needs to be fully compliant with the quality standards for teledermatology. We shared this with you at the beginning of the commissioning. Next slide. So this covers all the 8 standards, and because we are using an already existing NHS service, electronic referral service, all the information governance, all the record keeping, all the audit trail is there, so we don't need to worry about that. Selecting the patients I've already covered about inclusion and exclusion criteria. Gaining the informed consent is going to be a few. I'm going to go back to this in a moment. Competent staff. Initially, teledermatology, it was only supposed to be provided by consultants on the specialist register. Now, with COVID and the pressures on the departments, it is allowed for other colleagues to be involved. And at the moment, I have 2 registrars doing this with me under my direct supervision. And it's important because this is a way of increasing the capacity, but also to teach them teledermatology, because it's clear that this is unfortunately the way forward, and they are going to have to provide teledermatology over the next few years. Next slide. We're going to talk a little bit about the quality of the quality and the suitability of the images as well during this presentation, and the audits that we've done. Next slide, please. So this is one of the audits. So since we started the pilot, before initially with a few pilots that we did, and then since the commissioning of the service, we've been piloting the service, auditing the number of referrals that we receive, how many days we take to respond, the quality of the referrals, the conversion rate, and at the moment, before COVID, more than 60% of the referrals were advised only and asked the GP to manage in primary care. So those potentially 60% of them avoided an appointment in the hospital. We have reviewed the variety of cases that you've been sending us, and it is huge, and it represents the huge variety of presentations that you see in primary care. We review feedback that we receive from GPs and commissioners, and so far has been very positive. And we still have things to do, like, for example, patient feedback. This is something that I was planning to do before COVID, and we need to review at some point. And we should also audit the diagnostic concordance between the responders. So this is something that at the moment we're doing because we work in pairs. We do either two consultants together or the registrar and consultant together, and that allows us to see whether we are looking at the same thing, whether we agree with our treatments. And also we check our diagnostic concordance by comparing what we thought with the photo and what we thought when we saw the patient face-to-face or after a skin biopsy. Next slide, please. So gaining the informed consent, so this is key, and I've been moaning about this before because I think it's really important that we get this right. So the main thing is that patients should be given a patient information leaflet about teledermatology, explaining them why this is important, why this has been suggested for them as a pathway, as a way to be referred to us. And also it's really important to explain them the limitations of teledermatology, that obviously is not the same as the face-to-face consultation, that potentially there might be some diagnostic inaccuracy, they may need to be seen face-to-face at some point in the future, and that things can change as well. And that's important because we are seeing the patient sometimes at the very beginning of the evolution of the skin condition. So it's also important to tell them that obviously if things change along the line, they need to consult again or be re-referred again. We also need to explain them who will be taking the photos, although at the moment since COVID, I think most of the photos are taken by the patients. What will you be doing with the photos? In this case, they are sent encrypted to the advice and guidance pathway, and they should also receive, if appropriate, the response printed copy of the response that I've been given. Next slide, please. In terms of the consent, we've discussed this before. Because you're working paperless, I know you're not collecting the forms with the signature of the patient, but it's really important that some form of record of what was consented is kept in the notes, in your notes or in the e-referral. So ideally, and this is what most dermatology departments do, is that they take a photo of the consent form and they attach it as well with the referral. And that's something the patients could do themselves if they are taking their own photo. Why that is important? Because we need to know exactly what the patient consented for, if consented just for medical records, or if they consented for teaching purposes. So at the moment, we are not using any of these images for teaching you or teaching other healthcare professionals, but potentially this is something that we could consider, and other dermatology departments use the teledermatology cases during the evening and journal clubs that they have with the GP. So this is something we should consider. So when they consent for teledermatology, they consent for the photos to be used for their records, for their patient care, and potentially as well for audit purposes and for teaching the registrars in clinic, because they will be with me in clinic, and the patients need to be made aware of this. And another important factor of the consent is that obviously they are not under no pressure to give consent for teledermatology, and they should be aware that other pathways are available, and face-to-face is still available. Obviously, under the circumstances, they may not be able to be seen immediately, and they may not get the advice within 5 working days. Next slide, please. So this is the example of the consent form that the British Association of Dermatology recommends. And next slide, we have adapted this for BARTs. It's very similar with the patient information leaflet. So this is already available for you to use. If you don't have it, we can forward this to you. We can ask the CCG to give you a copy. So what I propose we do is that Patient sign this copy, they keep the copy and they take a photo and they attach it, please, with the referral. Next line, please. So the other few things I wanted to talk before we go to Dilshad to present us some guidelines is an update about what kind of clinical information is key. And the reason why this is important is because the service has expanded very much, and there's lots of GPs using it at the moment. Some of them are not familiar with the service, and some of the GPs are only attaching photos, and that in itself is of no use for teledermatology. It's super important to have some clinical information, because otherwise I may be giving you the wrong diagnosis or the wrong treatment plan. And in most cases, this is just resulting in a delay of the advice. I just start asking you questions, asking you need to then call back the patient, and it's only going to make it harder for you. So that's why we are proposing some referral forms that I'm going to show you in a second. And also I'm going to give you some tips to show your patients how to take good quality photos. And this is, I think, key now, because I'm sure you're seeing most of your patients remotely as well, and this will be helpful for you to get the photos right from the beginning. Ideally, if you're sending lots of cases, or if you're asking your admin team as well to send cases, ideally the photos should be identified with some number or some identifying number or the name of the patient to make sure there isn't any misidentification. And I also wanted to say, I know some of you use advice and guidance for clarification of test results or for clarification of plans because the clinical letter perhaps didn't arrive, and that's fine by me. I can also try and help with advice and guidance, but just to remind you, we have a specific email address. You can contact our admin team here in this email address, and therefore you don't need to pay for the tariff of the advice and guidance. Next slide, please. So this is the proposed referral form that very kindly Dr. Nazmul Hussain has made a start, and this is based on the standards, the British teledermatology standards suggest this is the minimum information that we need to respond your advices, your referrals appropriately. So just next slide, so we can go one by one every box. So this is just to remind the exclusion criteria. So 2B weights are excluded. Rashes suggestive of a severe drug reaction, erythroderma, blistering disorders are excluded from teledermatology. The last version of this proforma actually includes the mobile number of the dermatology SPR on call, so you can contact them directly 9 a.m. to 5 p.m. Next slide, please. Then, as I said, ideally, I should also prefer to see the photo of the consent form, but if that's not possible, at least please tick the box that the consent has been discussed with the patient, that the limitations of teledermatology have been discussed, and also please tick whether the patient is aware that photos could be used for teaching purposes and that the patient is happy for those photos to be used for teaching or for publication. Next slide, please. Then this is the minimum information required if you are asking us to give you advice about an inflammatory dermatosis, and it's just very straightforward. And most of you are doing it already, but I think this will help you to do it in a more structured way and to not miss any information and to avoid me having to ask you to get this information back from the patient. Next slide, please. This would be the minimum information needed for a skin lesion. Again, it's just very straightforward. Most of you are doing this already, but it's key to get this right and to get the best advice. Next slide, please. We have also included a body map, which will be helpful. So to identify exactly where are we talking about, I need to know exactly if you're sending me a photo of an arm because the arm was the only affected area, or if there are more areas, and perhaps the patient has only sent one arm because he was shy to send the other bits. But for me, it's really important to know which were the areas that were examined or that are affected. Next slide, please. And then suitable images, this is well covered in the British Association of Dermatology standards. They need to be of good quality. They could be taken with cameras or with mobile phones. They need to be at the moment, mainly patients are doing this with their phones, so it's not for you to know exactly the specifications of the camera, but you need to know these are the standards. And next slide, because there's a video I would like to show as well. So this, if you're taking the photos yourselves with your own mobile phones, it is accepted as long as you follow the standards of the UK guidance. I think this is not that common at the moment because most of the photos are taken by the patients, but just remember, if you're doing this yourself, it needs to be done with iCloud off and avoiding that the photos go to your social media. And next slide, please. So there is a very helpful leaflet that the British Association of Dermatologists has produced for patients, and I think you should be sharing this with your patients when you are requesting teledermatology. This explains the patients very clearly how to take their own photos, and is available for you to download from this link. Next slide. There is also a video, which it takes just 3 minutes. It's been produced by the Bristol Dermatology Department, by their medical illustration team. It's just 3 minutes. I invite you to watch it if you have a moment. Explains very clearly how to take patients, how the patients should take their own photos. And again, it could be shown to the patients and we will get best photos. Next slide, please. This is also already available for you to see in the Tower Hamlets website. It shows an example of what a good photo is. Next slide. This is a photo that will be blurred and will not give us enough information depending on what we're looking at. Next slide, please. Photos with flash are usually better because they give us better contrast. Next slide, please. Usually a recommendation is to have a ruler as well so we can see the size. Next slide, please. Depending on what we're looking at, it would be helpful to have an arrow as well pointing at it, because sometimes what you are seeing is either very subtle or with the flash, it may not be. If the flash, the photo was taken too close, the flash will be affecting the quality of the image, so it's important to have an arrow pointing at it. Next slide, please. We need to try and remind patients to have a solid background if possible and avoid taking photos next to the kitchen or next to toys or the library because the background will be distracting. Next slide, please. This is an example of photos from the face. Ideally, it should be from the front and both sides as well. Next slide. Ideally, photos should be taken, a panoramic photo of the anatomical area that is involved. For example, the whole head should be included, and then a close-up with more detail of what we're looking at. Next slide, please. Ideally, the whole rush should be included. So, for example, this one is an example of an intertrigo. Ideally, I want to see the whole rush and not just a little bit of it, because I need to see the stent and also the edges that are very informative as well. Next slide, please. These are examples of good quality photos of the trunk, ideally front, back, and side. Next slide. And limbs, it's super important to have photos of both limbs because we need both limbs to compare one with each other. Otherwise, I won't be able to tell you confidently if this is most likely a fungal infection or is most likely an eczema, for example. So if we could ask the patients to take photos of both hands, even if one hand only is involved, that would be very informative and very helpful. Next slide. Similar with the legs. Next slide. Feet. Next slide. It's also really important to take photos of complementary areas as well. So, for example, if you are, if the patient is telling you about hands, and it's a key to ask about feet as well, just to confirm whether this, for example, could be psoriasis. Ask about nails. Include the photos of, if possible. If hands and feet are involved, maybe ask about elbows and knees and scalp, and encourage to include photos, even if it's very subtle what they can see there, because it would be very informative for me to confirm the diagnosis. Next slide, please. So the rest of the presentation is just to give you an idea of what we're doing to improve patient care and to improve the pathway. So we thought in order to audit this further, as I said, it would be key to get feedback from patients and more feedback from you. I want to hear what's working well and what's not working. As I said, I'm trying to increase the capacity, and I'm working in a business case to appoint another consultant to expand this further, to start piloting to be weights very shortly as well for the next summer peak, because obviously, as you know, the summer is when the to be weights go completely out of control. Nazmul is going to tell you in a moment about what we're doing with the community clinic. I want as well to see if these sessions, for example, are helpful for you and whether you would like to have more of this in the future and what type of teaching opportunities you want. So apart from, I forgot to mention that one of the key things I do with advice and guidance is I always include patient information leaflets and links to websites, but perhaps that's not enough. I want to hear if this is something we should explore further with maybe more teaching sessions or case-based discussions based on the teledermatology cases. We're also working in these local guidelines. So in a moment, Dilshad is going to present you 3 or 4 of the ones that we are working at the moment, because we think it will be really important to have some robust clinical guidelines locally and to make sure that we are standardized how we are looking after our patients. And we're also exploring how to move to, whether we should be moving to RAS, to use this electronic referral service in a more efficient way to triage the referrals more efficiently. Next slide. So the guidelines that we're going to be talking about, I don't know if you're already aware, we have this available for you already in this website, the Tower Hamlets CCG website. So these were kindly shared by the Central London Community Clinic, Dermatology Community Clinic. So we adapted them about a year ago, and they're available in Word, but we thought we should make them a bit more attractive for you, maybe making them shorter and briefer. So this is what we're going to present in a moment, with 3 of what I think are the most common, the top skin conditions that you're referring at the moment. And I think that was the last slide. I think the last slide is just some, also I want to make you aware of really helpful learning tools for GPs about dermatology. These are available in the Royal College of GPs. These are fantastic, and I hope you have the opportunity to get into this and read them. And the next slide is just some references for you to read about. This is what we are using to support what we're doing. And thank you for listening.
Thank you, Rebecca. Okay, so we'll hand over to Dr. Dilshad.
Okay. Can everyone hear me okay?
Yeah.
So this next part of the presentation is the local dermatology guidelines, and like Rebecca said, the initial guidelines are there on the website to be accessed, but they're in they're in Word documents. They're not the most accessible. So what we've done is we've taken the existing guidelines and we've used PCDS and we've used the national guidelines, and we've tried to make them a little bit more aesthetically pleasing, and we've tried to make them a little bit more accessible from a GP point of view. The thing to say is that these are a work in progress. There's going to be a lot of changes, I think, that are still made to these guidelines, and any input or feedback is most welcome. And if you can think of things that are not useful about these, but something that might be useful instead, that would be really good. Some possible amendments that we might think of in the near future would be adding in pictures, like Rebecca said, from the teledermatology inputs, and also possibly for GPs who are confident using dermatoscopes, maybe pictures from that. It's just like teledermatology is not supposed to be an additional burden on the GPs in the area. It's supposed to be a tool, and it's supposed to be helpful. So what I'm going to do today is talk about some conditions which should be managed successfully in primary care. This is, if we go to the next slide, this is a list of all of the conditions that are going to be included in the guidelines. Obviously, some of them will end up being referred to secondary care, but the ones that we're specifically talking about today are the ones that we hope can be resolved in GP land. So next slide. So the general format of each condition is going to be presented in a similar format for each condition. So it should have key points, and with these key points we've tried to include things which you may not have been taught about already. So novel things that might be important rather than just the generic things that everybody already knows. There's also going to be clear guidance on when to refer to secondary care. So at what point do you then refer the condition to secondary care? We're also including images to try and help differentiate between common conditions that might be mistaken for each other. So in a second, you'll see with actinic keratosis, there'll be a comparison between actinic keratosis and squamous cell carcinoma. But there are lots of conditions that do look similar. So sort of like a clearer reference guide with pictures. And then each condition should have a pathway attached to it, which either ends in referral or resolution. So if it's good, it has to be one of the two. And so what we've tried to do is really adapt the guidelines to end in one or the other. So I'm going to talk about actinic keratosis to start with, and Rebecca, if you just interrupt wherever necessary. So actinic keratosis, as I'm sure you're all aware, is common sun-induced scaly condition, and it has the potential to become malignant. Specifically for someone who has between 7 and 8 AKs, the chance of one lesion transforming to a malignancy in 10 years is 10%. So really it's important to think about what the risk benefit is for each patient, and if you have someone who may be palliative or someone who may not be bothered by their lesions, it's important to think about that statistic when deciding whether to put them through the treatment process for it. They're most common in the sun exposed sites of elderly people, so sun protection is vital, and the earlier lesions may be just erythematous patches, and later on may result in a more sandpaper-like lesion. Men are more predisposed to this than women, and 20 to 70% will go away by themselves, and 15% will recur even after treatment. The 2-week great referral criteria is quite straightforward. So if it's a painful lesion, if it's ulcerated, if it's indurated, or if it's growing and bleeding quite quickly, then that should be referred to secondary care. And also for patients who are immunosuppressed, particularly post-transplant, or younger patients. So by this, we're talking about patients under the age of about 45. You want to think about secondary care referral. If the lesion is quite crusty looking, you cannot assess the lesion until the crust has been removed. So you apply liberal emollient creams and moisturizers until you have a better idea of what's under the crust. And if we go to the next slide, here we've separated it into stages. So stage 1, broadly speaking, is the conservative management, making sure that the patient's using adequate sun protection, using the moisturizer, like I said before, 2 or 3 times a day to start to differentiate between what's an early actinic keratosis and what's more likely to be dry skin. Education, so just making patients really aware of those 4 things which would necessitate a referral to secondary care. And then stage 2. Now, stage 2 applies to discrete small lesions. So these are lesions which, when you get that sort of 1 or 2 lesions on the scalp or something like that. And for this, you can either go with the Effudix pathway, and you use it once nightly for 4 weeks, making sure not to apply it to the surrounding skin, washing off in the morning, and then giving them 3 weeks after that initial 4-week period for the inflammation to calm down. The Acticarol solution is just Effudix plus salicylic acid, and it's used once a day for 6 to 12 weeks. The key thing with this is to peel it off before you apply a new layer, and then cryotherapy for those GP practices that are providing a cryotherapy service. Rebecca, is there anything you want to add to that yet?
Yes, thank you, Dilshad, very well. So the reason why we are starting with actinic keratosis, really, I know it's an area where GPs may be a bit uncomfortable treating actinic keratosis, particularly using Effudix. And the reason why I'm suggesting actinic keratosis is because they are mainly affecting elderly patients, and they are very vulnerable in terms of risk of COVID infection. And it is not something that we at the moment they will be benefiting from coming to hospital. So the main message, the key message is when to refer, when they definitely need to come, and is when, as Dilshad has said, when there is any sign of this, could they be developing an squamous cell carcinoma, then yes, definitely we would like to see them. But if there are no signs of that, if they are just a stable actinic keratosis, as Dilshad is saying, some of them, they don't need treatment. We can just reassure the patients or the carers, and we can just recommend some protection, emollient, and strict monitoring of the lesion. If they are bothering them for any reason and they would like to explore treatment, ideally, if possible, it should be, if they are clear-cut actinic keratosis, it should be in primary care at the moment because of COVID. If you feel comfortable using Effudix, I would like you to encourage to use it, although I understand it is a cream that can cause such a severe local reaction that most of you are not keen to try. If we are going to go, if you are prepared to use Effudix, I'm happy to do this with advice. If you send me a photo, and I can advise you whether, yes, I agree this is actinic keratosis or not. And if you're prepared to use Effudix or Acticalar or Aldara, it's super important that you provide the patient with a patient information leaflet and show them some photos as well of how it can end up. The local reaction can be very severe, so they can be prepared for that, and they can opt to treat it or not, or to wait a little bit. So as Dilshad was saying, depending on the lesion, you would opt to treat. If it's just 1 or 2 lesions, ideally we will be treating them with cryotherapy. If that's something that you have you're trained to use and you have available, that's fantastic. If not, Effudix or Acticaral is a good option for individual lesions. If the patients have what we call cancer field change, if they have multiple coalescing lesions, for example, on the scalp or the dorsum of the hands, then they would definitely benefit from some field-directed therapies such as Effudix. Effudix is usually our preferred one because it's the most effective in all the head-to-head studies. But it's also the one that causes the most the vigorous reaction. I know in primary care you usually start with Solaris, and I'm sure it works as well. We are biased because by the time they come to us, it's usually those patients that have not responded to Solaris. But if it works for you and you've used that before, start with Solaris as well. And what we would normally recommend for patients that have large areas is to use it in stages. So if, for example, if they have the whole scalp, I normally tell them to start with the forehead first, treat that area first. Once that area is treated, treat the vertex, then treat the back of the scalp. Or if it's the hands, I say treat one hand first and then treat the other hand. And I always show them photos of how bad it can look and give them patient information leaflets and tell them if the reaction gets very bad, they need to stop and wait for a few days, either put some moisturizer, or if it's really bad, some small amount of Eumovate for a few days. Dilshad has included photodynamic therapy there as well, which is one of the treatments that is licensed for field-directed therapies. Unfortunately, that's at the moment not available at the Royal London Hospital because of COVID. We have had to prioritize services, and the nurses either have been redeployed or they are mainly helping with surgery at the moment. So photodynamic therapy is not currently available, but before that, we will always be considering things like, for example, Effudix, Solaris, or Aldara first.
Okay, so thank you. So going back to the slide, for treating field changes, again, it's Aldara, Solaris, Effudix. Acticaral isn't used in field lesions because it's such a small tube, and to treat a field lesion, you need to use a greater volume, obviously. So if we go to the next slide, for each guideline, we've tried to just put it into a sort of a summary slide. This one, something's gone wrong with the first box, but apart from that, every slide is a summary slide, and at the bottom of the summary slide, you'll find the link to a patient information leaflet, which you should just be able to click on once the guidelines are on the website. As you can see in this one, it either ends in resolution, or for here, we've said review after 8 weeks, and if it's just not getting better, then you can use the advice and guidance dermatology pathway. Okay, next slide.
Sorry, Dilshad, can I interrupt?
Sure.
The reason why we have suggested to remove the surface crust of the lesion, you may be wondering why we're saying that, and most of you may have done it before or not, and maybe you don't know what you're looking for. So the reason why we suggest that is for those lesions that could perhaps be a basal cell carcinoma. So that's the reason why we wouldn't be always removing the crust. So if it's a clear-cut actinic keratosis, then we just treat it. But if there is any suspicion of it could be a BCC, sometimes it's a good idea to gently remove the crust and see if there are typical features of a BCC, because obviously that would be needed to be treated in a completely different way.
Okay, thank you. And then the next slide is just shows the difference between, as you can see, it's very subtle. But I think, as Rebecca mentioned earlier, if we remove the crust and if we're using emollients frequently, obviously if it's obviously ulcerating and bleeding and causing pain, then that would warrant a referral. Okay, next slide.
Sorry, can we go back to the previous slide?
Yeah.
So exactly. So as Dilshad is saying, if it's already crusted, ulcerated bleeding, then that's not an actinic keratosis. That's potentially a BCC or a poorly differentiated squamous cell carcinoma. So we wouldn't be fiddling with these with creams. We would just expect this patient to be referred to the weight pathway. The photos on the right show potentially SCC. So if you can see, the base is raised and indurated. It has some rolled edges there, so that is potentially, that means that the lesion is not just a superficial actinic keratosis, it's something else. So this is the things that you need to look at, not just the crust, you need to look at the base as well. So if you see infiltrated base underneath the crust scale, or if the lesion is growing rapidly, then refer to us, because topical treatments will not work. We need to do at least some surgery, at least some excision or a shape excision, depending on the patient's circumstances and the location.
Okay, so the next condition that we're going to talk about is alopecia areata. So this is a chronic inflammatory disease that affects hair follicles, and it causes patchy, non-scarring hair loss. And non-scarring just means that there's no inflammation and there's no other signs of damage to the skin. It's just the hair loss. 20% of patients will have a family history, and the etiology is probably autoimmune because it's also related to things like diabetes, Addison's, thyroid conditions. So the characteristic findings, as you can see from this picture, is that typical exclamation mark sign, and it can affect hair on the scalp, it can affect eyebrows, it can affect eyelashes. So you can reassure patients that for the most part the hair will grow back on its own, and only in few cases is it permanent. There was a study done in Japan which showed that 80% of them spontaneously grew back. I think that was within a year, and then progression to alopecia totalis, which is when you lose all the hair on the scalp, was only 10%. And if we go to the next slide, so reassurance is at the top of this pathway. You can do bloods to look for anemia, iron studies, particularly if it's more diffuse hair loss, thyroid function tests, and then if it's multiple small patches and there's kind of an obvious history there and there's risk factors, then you can send off syphilis serology. Dr. Goiriz, do you want to talk about the blood test for it as well?
Yeah, so it's, as Dilshad is saying, and as you know, it's usually an autoimmune condition, so it's good practice either to ask about family history, diabetes, thyroid problem, and to suggest at least a screening of thyroid. And there is the reason why syphilis is suggested usually for the investigation is for those patients that have there's a very characteristic type of alopecia associated with syphilis, and it's different to the one that you usually see. So this wouldn't apply for patients that have clear bald patches. This is different. This is for patients that have the mottled hair loss, and if that's the case, it's just you recommend a syphilis serology. And again, why I have suggested alopecia areata to start today is because at the moment we are very restricted with the number of patients that we can see. We are going to have to prioritize our news, And alopecia areata is potentially a condition that is could self-resolve, and also a condition that should be treated first in primary care if possible before referring to us. So the main thing is patients can get very distressed when they start noticing any hair loss in general, but also with alopecia areata, because it can be very obvious. So it's important as well counseling and patient support with patient information leaflets, and then start the topical treatment, reassuring the patients that potentially this will regrow within months. And we usually recommend topical steroids, potent topical steroids. This is something that should be done in primary care before considering referral to us. And we used to be able to provide intralesional injections of the steroids. We were doing things like defensive prom as well in the clinic. We were using phototherapy as well and considering immunosuppressants, but at the moment we're going to have to be very limited and very discuss very carefully risk balance of doing something like this during COVID. So that's why we would like to encourage you to try topical treatments first for these patients.
And the steroids of choice here would be betamethasone or clobetasol, and trial those for 3 months. Okay, so next slide. So fungal nail infections are incredibly common in general practice. The typical advice with this is not to give the oral antifungals until clippings have shown that it is actually a fungal nail infection. That's because of the effect of the liver toxicity effect of some of the agents used to treat fungal nail infections. Something that when we were putting the guidelines together, I actually found out about was 2 feet, 1 hand syndrome. So sometimes you can have patients who've got it in both feet, and the hand that they're using to either pick or treat the nails can actually become affected too. So that was just a fun fact. Next slide. So topical treatments have a low cure rate, but they might be suitable for treating distal nail infections or superficial nail infections. Patients should always be encouraged to file the surface of the nails, because the keratin at the top needs to be filed so that the treatment can be absorbed into the actual matrix of the nail. Amorolfine is the most commonly used one. It's got a good side effect profile, and it should be used for 3 to 6 months for fingernails and 6 to 12 months for toenails. Canis Pro, which is a combination of urea 40%, which softens the nails, and an antifungal, can be used instead for patients who are not tolerating these. And Canis Pro can also be used in addition to the oral antifungal treatments. Oral antifungal treatment, so terbinafine is the most effective treatment for fungal nail infections. You should check LFTs before you start the treatment, and then every 4 to 6 weeks whilst they're on it, and you discontinue if there are any abnormalities in their LFTs. If they can't take terbinafine, then you can try itraconazole instead, using this pulse therapy option. And in kids, it's important to always look up the dose in the children's BNF. But there's a link there to the British Association of Dermatologists for more specific guidelines. Rebecca, I don't know if you wanted to add anything to that.
No, I think this is incredibly common in primary care, and it can be really difficult to know if this is a true fungal infection or if it's an onychodystrophy for other causes. So again, it's another situation where if you're sending me photos, it would be very helpful to see all the toenails, because if it's multiple involved, is potentially something else. It could be psoriasis of the nails. It could be related with deformity of the nails, and of the toes, that perhaps it's causing the nail problem if the shoes are very tight. I really would also like to know what type of shoe where the patient uses regularly, whether they're too tight, whether they are wearing heels or trainers all the time, because all these things matter. They also matter if the patients are having potentially recurrent nail infections as well. So ideally, nail clippings should be sent before, because otherwise, after 6 months of treatment, you may end up in the same situation. You may end up looking at the nails thinking, where are we? We don't know. We don't know if he had a nail infection before. So ideally, it should be done. And it's also very important to make sure the sample is correct. The nail clipping needs to include piece of nail and also the subungual material, the hypokeratotic material, because that's the best chance of picking up the fungi and send it to the lab as all the sample or the relevant sample to increase the pickup rate and reduce the chances of it being false negative.
And finally, we're going to talk about vitiligo. So vitiligo is defined as the complete loss of pigmentation arising in discrete patches of skin. It occurs in about 1 in 100 people. The importance with the discrete patches is with things like pityriasis versicolor or pityriasis alba. The edges can look quite blurred, whereas with vitiligo they are more discrete. The etiology is not fully understood, but it's thought to be a destruction of melanocytes, and that there is a hereditary preponderance to that as well. It's associated with patients who also have things like Addison's, thyroid dysfunction and diabetes, and it's of course very debilitating. So psychological support counselling is key in these patients. It's often first noticed on the face, the neck and the hands, and it's usually symmetrical, which is another differentiating feature to things like pityriasis versicolor. Hair-bearing areas may show premature graying, so as you can see there, the eyebrows and eyelashes are affected as well, and it displays Koebner phenomenon, so areas which have undergone trauma can show localized depigmentation as well. It's not usually itchy and doesn't usually bother the patient apart from the aesthetic appearance. So the next slide. So like I said, psychological support is extremely important. It doesn't usually reverse itself spontaneously. Vitamin D supplementation, this is something I didn't know about until these guidelines. It should be considered for all patients with vitiligo. You can offer referral to a camouflage team, or if you don't know of one, then there's a charity called Changing Faces, or speak to your local dermatology service. Rebecca, I'm not sure if, yeah, okay. Patients are less likely to benefit from treatment if it's at the extremities and more likely to benefit from treatment if it's central. So for facial vitiligo, you tried tacrolimus in the first instance. Obviously steroids have their risks with skin thinning and hypertrichosis, and so you don't want to be using a very potent steroid on the face if you can avoid it. So tacrolimus 0.1% BD or Protopic, as it's known, can be considered. And there it says 6 months, but I think Rebecca, you said 3 months, and then.
Yes, I would normally recommend 3 to 6 months initially. If it doesn't work after 3 months, it's less likely to work. If it does work, then I tend to tell them to reduce the applications to twice weekly or once weekly. And as I was telling to Dilshad as well, the new guidelines, the new vitiligo guidelines are currently in draft process. They will be published very soon, but what they recommend is actually to start with Protopic on the face rather than topical steroids, or consider alternating topical steroids with Protopic on alternate weeks. So mometasone with tacrolimus on alternate weeks, and that is to reduce all the potential complications of skin thinning. The same for other areas, for example, armpits, groins, genital region. The reason why it's important the location of the vitiligo, it's important to manage the patient's expectations as well, because the way vitiligo repigments is from the hair follicles. So if it's periungual or if it's on the hands, it's less likely, hands and feet is less likely to repigment. So it's really important to tell them initially that so they don't treat unnecessarily. And the camouflage is key. We used to have a nurse in the service providing camouflage, but again, she's currently redeployed. So I don't know if this service will be available, but if this is something, as Dilshad mentioned, if this is something perhaps you could suggest to try changing faces, or just to prescribe the camouflage on the NHS as well. Cover Mask is one of the brands that we use.
And I mean, that's the last topic we're presenting today. There are obviously going to be other topics and other presentations, and like I said, this is all a work in progress, so any feedback is very welcome. And that's all for me. Thank you for listening.
Thank you so much, Dilshad. Well done.
Okay.
Thank you very much, Dilshad.
Thank you. I'm going to leave because I have another meeting, but thank you very much.
Thank you.
Okay.
So I want to spend the next few minutes on the proposed dermatology pathway. So we know that there is immense pressure in secondary care with high volumes of referrals for skin-related problems into dermatology, and with the coronavirus issue, we kind of need to work in a probably more smart way and more efficient. Some patients may be shielding, some may not be able to go into outpatient clinics for their appointments. And when you ask patients, they're actually extremely happy with photos being taken and submitted and for a consultant to have it reviewed. So we're trying to optimize that pathway and see how we can make it more efficient. So what we are proposing now is this is what the community dermatology pathway may look like. So the existing community dermatology services for Newham and Waltham Forest, we would expect that to continue. And I know that Tower Hamlets do not have a community dermatology service, so we are looking to ensure that there is one there. So this is here, the community dermatology pathway. For appropriate referrals, those patients get managed. If it's inappropriate, then they get referred back to the GP. So now we are trying to use this new teledermatology service. So as Rebecca has described, so these are for non-urgent 2-week wait referrals and conditions that don't require kind of emergency admission. So those referrals that are suitable for community would go ahead as usual. But those patients that you feel I feel this patient needs to be seen in secondary care or referred to a consultant dermatologist, as you would do normally, rather than refer them into the hospital. Initially, what we would expect you to do is complete a referral form, as Rebecca went through, and that form needs to be submitted through email with consent, with the photos, and submitted via ERS. Very similar to what we do for our virtual CKD clinics, where you can book into the ERS service. That will then get triaged by someone. This is what we're working on at the moment. It may be that the community provider does the screening, or it may be secondary care consultant or registrar does the screening and then decides, well, actually, this patient could be seen by the community dermatologist and gets directly booked into community rather than revert back to the GP and the GP having to do another referral. The second outcome could be you get advice from the consultant or the GP with special interest in dermatology around the management of that condition. So it may be actually treatment is with A, B, and C, or just A. Please manage accordingly with the proper advice, and you can always leave that service open, and then once it's resolved, you can close it. The third outcome might be, well, actually, this requires an outpatient appointment for a patient to be assessed. So that could be initially a virtual assessment by the consultant or secondary care colleague, and conversion into a face-to-face in the outpatient clinic. The third stream is what we're working on, will be working on, is the 2-week wait. So at the moment, we don't have a service where we can remotely take pictures using the dermoscopes and then submit it. That is a potential option and a pathway that we could implement, and from the pilot in Leeds. They have done it quite successfully, and there's absolutely no reason why it can't be implemented across WEL. So in a nutshell, that is the summary of the proposed pathway. It will obviously need to be tweaked and refined based on user feedback and patient feedback. So that is what we're working on at the moment. Other exciting projects that we're working on is the community pediatric dermatology pathway, which may look similar to this one. Usage of apps which are patient friendly. So for example, a patient may have been referred to secondary care and needs a follow-up. So rather than going to the hospital for a follow-up, they could use a specific app to submit pictures to secondary care colleagues or even primary care colleagues for a review and update. Teaching and education. So this is the first WEL based dermatology seminar. We will provide more based on colleague feedback and advice. And hopefully with Rebeca and Dilshad, we will have a manual or a directory of common skin conditions with relevant advice and references and guidance. We will start working on the usage of dermoscopes. So there are really quite smart digital tools out there where you can attach lenses, dermoscopes onto your smartphones, and you could use them to take pictures and submit them if you suspect a 2-week wait. But that is a project which we will work on more intensively as we go in the weeks. So that's it from me, really. It might be useful now to pause there and open it up for any comments or Q&A. Before I do that, I have a question for Rebeca around the fungal nail infection. So when we send off for mycology, sometimes we have the stain, the calciphos stain comes back positive, and sometimes it's negative. When it's negative, the appearance is quite suggestive of fungal nail infection. What do we do then? Do we submit for more nail samples, or what would you advise?
Well, again, I think it will. This is a really very good question, and it will depend on how many toenails are involved. So if it's just one toenail and it does look clinically fungal, and there is no risk that it could be psoriasis or onychodystrophy for any other cause, and the patient is fit and healthy and there is no contraindication, then I guess it's a question of risk balance, and you can perhaps take another nail clipping but start the treatment at the same time, because it's very difficult to get complete clearance as well after 3-6 months. Sometimes patients need longer treatment, and that is the risk. And there is although the aim of the guidelines, the aim of the treatment is to get complete clearance of the infection, it might be quite difficult. So the guidelines, the recommendation is to take the clippings if possible. And that's what I prefer to do as well. Based on my relatively still shorter career, I prefer to do it that way to be safe. But obviously I understand you have to work in a more pragmatic way as well. I think the situation is completely different if the patient has several toenail infected or toenail affected, sorry. So that may be some other cause. And there may be contaminants as well that they don't represent, they don't mean that they are pathogens, that they don't need a full course, 6 months course of oral antifungals.
Thanks, Rebecca. So I'm going to ask Joe or Sarah to see on the chat if there are any questions from our colleagues. Or if anybody wants to, I'm happy for them to unmute and ask the question, because I know there might be some sort of bug which may not allow patients to raise their hands and express the comments. So if you want to, please unmute yourself and ask a question.
Yeah, we've got no questions in the chat at the moment, Nazmul.
Okay, it's maybe because there are truly no questions, or the bug may have affected us. So
yeah, raise the hand. If anyone can raise their hand, that should still be working for everybody. So if anyone's got any questions.
So Emma Radcliffe has raised her hand. So Emma, please come forward and ask your question or comment.
Yeah, hi, I'm Emma Ratcliffe. I'm a GP in Tower Hamlets. I'm just wondering what the benefit of the community dermatology service is, because actually advice and guidance seems to be working quite well, and if you know, and it was really providing a really good service. Thank you, Rebecca. So what, and if you need to see patients, then you can see them. So what more would a community dermatology service add for us in Tower Hamlets?
Do you want to answer that, Rebecca, or? I think looking at the numbers, comparing to Newham and Waltham Forest, the numbers of referrals into secondary care, where they've got community dermatology in service, has been significantly lower than Tower Hamlets. And looking at the data, I feel the community dermatology services have taken on that burden from secondary care. So it would reduce the referrals into secondary care.
So thank you, Emma. I don't have probably the information regarding the activity to tell you right now in front of me, but it's also an opportunity to expand the capacity. We have a very stretched dermatology department, and patients are waiting very long to be seen, to be honest. And I've been working as a clinical lead for the last 4 years. We've tried numerous ways of increasing the capacity, expanding clinics, doing weekends, outsourcing, insourcing, training nurses, upskilling other, and trying to do nurse-led clinics. And it's really difficult, because the difficulty as well we have is, even if we work harder, even if we reduce, if we see your patients, we also get patients from out of areas as well. Although at the moment we've managed to close out of area referrals during COVID, but before we were told we were not allowed. So it is, I suppose, from my perspective, it's another pair of hands, safe pair of hands, and they would be experienced because they've run community clinics before. It will be working together, and it will be in addition to advice and guidance, not instead of advice and guidance. But yeah, I take your point, and if it's not something that you want us to explore, definitely we will consider that.
Well, I'm sort of slightly speaking with the LMC hat on, because it was sort of discussed in Tower Hamlets at LMC, and I think we would always really support just our local secondary care provider. You know, if you are able to see, we would prefer you to see and to build the links. You know, and that was very much the feeling when it was discussed. So yeah. Sure,
and it will not be instead of us. It will be together, and it will be part of the pathway. So advice and guidance will be offering that opportunity to triage referrals, those things that we think could potentially be seen sooner in the community rather than us, depending on the circumstances, depending on the capacity. So if, for example, if they're able to do things like, for example, prescribing isotretinoin, it would be very beneficial. They don't necessarily need to come to secondary care and have all the monitoring in secondary care. But it would not be they would not be working in isolation. If we do this, it will be partnership and integrated. So where it has worked very well, very successfully, is in, as Nazmul is saying, is in Waltham Forest. They work really close together. The consultants work with them, and in Newham as well, because we didn't have a dermatology department in Newham, so they are very experienced as well.
Thanks, Rebecca. Yes, unfortunately, we don't have enough Rebeccas to deal with. Imagine Rebecca is seeing all our advice and guidance, and at one point, it may not be clinically safe to take on such workload, and there aren't, extra consultants available. So I do appreciate colleagues' concerns and issues and anxieties they may have, but I can assure you that the community dermatology and secondary care will be working hand to hand with designing the pathway and ensuring that referrals are appropriately, safely, with the appropriate governance in place, looked after and dealt with. So, and we always welcome feedback from colleagues. So when something's working well, and that's great. If something's not working quite well, then it can be reviewed, and we can certainly retweak things.
I think we probably just feel that we've had a not particularly positive experience recently, and in the relatively recent years, and now COVID is suddenly, everything is a bit more functional anyway, but I'll leave it there. Thank you very much. Thanks.
Thank you very much. We have a hand from Talat Ahmed. Thank you very much for coming forward, Talat.
Hi. My name is Talat Ahmed. I'm a GP in Tower Hamlets too. I work at Strouts Place Medical Centre. I was just saying, I think what Rebecca was mentioning about so pre-COVID, if we go back, I remember, and even now I'm sure, to get a face-to-face review with a dermatology consultant, patients will be waiting 6 months or so. I'm astounded by the quality and the efficiency of the teledermatology. It's amazing. But as you said, Rebecca, you're working on the weekends. You can tell because you can see the dates and the timestamps and things. You're really working super hard, and that doesn't really. We can't rely on a system that relies on just certain people working like 24/7. So I do think that GPs are well placed potentially to help with this problem. And I understand, Rebecca, you're also trying to help train GPs with dermoscopy and things like that. And because of COVID, a lot of this has not happened. So that's something I think that it will be really valuable to help unburden the workload and secondary care colleagues. So you can focus on the more complex things, dealing with maybe biologics, those kind of things, which as GPs, we shouldn't really be going there. But yeah, I agree. Acne, a great example, very simple problem to solve. Isotretinoin monitoring could be done if it's the right person in the right hands. I think even some areas where I trained in Harlow, they had nurse-led clinics for dealing with these things. So it does make sense to me. I think it's the right direction to have more GP input in some of these things, which are very relatively simple, but maybe if you've got the right training basically and the right education behind you, then I think you can deal with a lot of these dermatological things in primary care.
Yeah. Thank you, Talat. That was really kind. And so one thing I forgot to mention is that part of my role at BARTS is also teaching GPs. So I work for the postgraduate diploma in clinical dermatology with Queen Mary University. So we know some of the GPs, local GPs and other areas of the UK that have wanted to progress to GPs with a special interest in dermatology. And we promote that training, and we now have one GP that has recently completed the training, working in the department with us to upskill and to get the qualification as a GP with a special interest. So the idea of the community clinic, hopefully, would be to get people that we've trained ourselves, that we know who they are and we can rely on, and not just getting a private provider. That's definitely not what we want.
Thank you. Are there any more questions or comments colleagues have? Okay, great. So I can't see any more hands raised or anyone wanting to ask questions. So with that said, we will promote and advertise more sessions, and feedback is welcome around topics of what you want delivered. There are also really exciting projects coming along around teledermatology, referral pathways. So we will update you when that is appropriate. So with that said, I thank you very much for joining the teaching session, and take care and look after yourselves. Bye-bye.